the sun and the sea.
Well, here we are. Hello, hello. All right. Good evening. I think we've got our technical things working. So should I put up a slide? Perfect. Well, good snowy evening to everyone. My name's Betsy Brew, and I just want to welcome everyone to the fourth session of the Valley View University about the from the Breast Center. And
We're just gonna share your screen so that you can
Okay.
show your one,
one slide.
yeah. And then I'll stop sharing.
Perfect. So I'm going to keep talking while we're working on this. So for those who don't know, I'm Dr. Betsy Brew. I'm a breast surgeon here at Valley View and working with the Breast Center, which is really an outstanding program. This is the fourth talk that we've given. The first I talked about benign breast issues. Then Dr. Weathers and Becky from the imaging department talked about mammograms. And then after that, we had the nurse navigators from the Cancer Center go through what happens if someone gets if you get diagnosed with the breast cancer, how do we take care of you and what do we do? And so, as you might remember from that talk, the next step is thinking about surgery. And so the flow after someone's gone through their mammogram, found out they've had a breast cancer, they end up seeing a surgeon. And so for anyone who's seen me already, they will have heard a lot of this talk because it is what I talk about when I first meet someone who's been diagnosed. What they don't know, or what you wouldn't know, is that this is my grandmother, Betty. Luckily, I got called Betsy rather than Betty, who lived 70 years, and she died in 1976. I know from a breast cancer, again, in 1976, no one was really talking about these things, but I think she had a metastatic breast cancer. And I certainly know that she had a mastectomy, and I'm not quite sure all her other treatment. 1976 was a long time ago. And so our world is very different now when someone's diagnosed compared to when she was. So I just wanted to kind of give you that. You've never, even if you've heard the story, you've never seen my grandmother. So it's interesting that in a brief history of the surgery for breast cancer, they first started doing surgery in the late 1800s or mid 1800s. And at that point, it was a really horrible surgery that was done. Women had their chest wall muscle, breast, all their lymph nodes. I mean, it was really very traumatic. Not that breast surgery in 2022 is not, it's still traumatic, but it was just really scarring. It turned out that actually women would survive that, but the price they paid almost wasn't worth it. Then throughout the early 1900s, up until 1976, all women had mastectomies. No one had any other way to take care of a breast cancer except to remove the entire breast. And then in 1976 or so, a very brave, smart surgeon actually said, well, maybe we don't need to remove all this normal breast tissue, with the idea that women aren't necessarily going to live any longer. So it was really in the 1970s, 1980s that women started having a choice about what sort of breast surgery made sense for them. And so when I meet someone who's been diagnosed with a breast cancer, I start out the conversation by saying, thank goodness it's 2022. We know so much more than we used to, and you have great choices about what sort of surgery to do. A lot of women, as you can imagine, come in overwhelmed, scared, alarmed, sort of thinking, yeah, what I'm going to do is just do bilateral mastectomies and be done. And it's really nice to be able to give options that are just as good as putting yourself through something like that. So in general, and this is a very general discussion, and there's a lot of fine points that go, that will vary from woman to woman. But in general, women who are diagnosed with a breast cancer have choices about what surgery to do. And the really lovely thing about these choices is there's not one surgery that's better than the other as far as curing a breast cancer. And I think that is the most important thing to hear from this talk. I know it's like, will I be able to keep my breast? But the most important thing to realize is that you're not shortchanging your survival. You're not jeopardizing your future by your surgical decision. And so women can do anything from doing a lumpectomy, which is just like it sounds. It's taking the cancer out, making sure it's out with good clear edges around it. And then most often we'll remove a lymph node from under the arm just to be sure there's no cancer there. The whole goal of surgery is to get the cancer out and make sure the lymph nodes are okay. So you can do that as simply as a lumpectomy. Women can do a mastectomy, which is removing the entire breast. You could do both sides mastectomies. And then our next topic in this series will be Dr. Butterfield talking about doing breast reconstruction. So you can do breast bilateral mastectomies, one side mastectomy, or with or without reconstruction. So you can imagine there's a vast array of immediate surgical decisions that women need to make. And everyone's different. I think that's the other thing that I really appreciate doing this is that it's not one size fits all. And it doesn't really depend on age. It doesn't really depend on, whether someone's married or not, or in a relationship. Every woman's got a very different sense of what's important to them. And so, or what's important to her. So there's certainly advantages to doing less surgery, especially knowing that you're not jeopardizing your health or survival by doing a lumpectomy. And then I'll do a lymph node sampling. The tremendous advantage of that, and a lot of women realize this, is that it's easier. It's easier surgery, easier recovery. It's done outpatient surgery. Most women will take maybe a week off after work, but it's not after surgery, but it's not something that you go home with a lot of pain medicine or anything like that. And there is this just general, again, compared to my grandmother, who we called Oma, she didn't have a choice. And it's just nice to have a choice. And it's nice also to not have to remove normal tissue that's not going to give you a survival advantage. So lumpectomies really are a tremendous option. There's always a downside, and this is why some women will choose not to do a lumpectomy. One, and this is not a medical downside at all, but women who do a lumpectomy need to be followed. So you need to get a mammogram in 6 months. We get another one in 6 months. Sometimes we get MRI. So there's certainly closer follow-up that's involved. And I would say a lot of women who I think would be great candidates for a lumpectomy choose to do a mastectomy just because they're worried. And that's the really, again, wonderful thing about having choices is that we can make a decision that fits and lets someone live their life without worrying about it. I can say, medically, scientifically, there's no survival advantage to doing more surgery, but for some women, it's a lifestyle peace of mind decision. And so that's totally reasonable. I think the other downside, and this isn't as true as it used to be, but you have to think about radiation. It used to be every woman who had a lumpectomy did radiation afterwards, with the idea that there's breast tissue left there. So we've done the lumpectomy. I've gotten it all out. Everyone says that the margins are clear. You don't know if there's a cell that's there that could turn around and give you a hard time later on. So almost all women that do a lumpectomy have to think about radiation. Luckily, just like we're doing less and less surgery and sort of downstaging the treatment, luckily not everyone needs radiation. And certainly there's been great science showing that women over the age of 65 with well-behaved cancers don't really benefit for survival wise from having radiation. But at the same time, if you choose to do a lumpectomy, you do have to at least consider radiation therapy afterwards. Radiation's not hard. It's not chemotherapy. It's a tremendous inconvenience, especially in this valley and in this area. It is something that you have to come daily to Valley View, to Glenwood. And you either get treated once a day for 3-4 weeks, or you do twice a day for 5 days. I mean, there's a lot of finer details, but you do commit to doing radiation. Again, it doesn't make you sick. It doesn't make your hair fall out. It's not chemotherapy, but it's a real commitment of time. And so for some women who live far away and don't have the time, they will make a decision based on that radiation. So lumpectomy, the other choice is doing a mastectomy, which is removing all the breast tissue, again, sampling a lymph node under the arm. The good thing about that is that you don't need mammograms, you don't need ultrasounds, you don't need any sort of x-rays of that area because there's no breast tissue left. You're not going to live any longer. If you have a cancer that you need to think about chemotherapy, the fact that you do more surgery doesn't change that. You still have to do the same treatment that we would recommend if you had chosen to do a lumpectomy. But for some women, again, that's the way they will live life better, is not having that worry or concern or have to go back in 6 months and fret and stress about a mammogram. No survival advantage, but maybe some untold psychological advantages for some people. And it's very unusual to need to do radiation after a mastectomy. So that's another advantage. There are some women who choose to do both sides, but we'll say bilateral mastectomies, which the one time that makes sense medically, and this is a very small percentage of women diagnosed with breast cancer, like in the less than 10%, is if there's a genetic mutation. So if someone has a gene mutation that we identify after you're diagnosed with a breast cancer, then I will say there's no choice, or there's always a choice, but there's not much of a choice. You really do have to think about doing bilateral mastectomies because there's such a high risk of getting another breast cancer in the future. And on our schedule of talks coming up, not till next spring, the genetic counselor is going to talk about genetic counseling and genetic testing. Again, it applies to very few women, but women who do have a gene mutation, that is a group that I'll absolutely encourage and support the doing both sides mastectomies. Otherwise, there's really good studies out there showing that there's really not any advantage to doing both, and you're taking on twice as much surgery, twice as much recovery, twice as much risk of complications and everything else. But that being said, there are women who decide to do both sides just because symmetry, for lack of a better term. There's some women who are very large breasted, and if they have a mastectomy on one side, it's very uncomfortable to have one breast that's quite large and one that's not. So there are times that we'll do both sides just for a balancing thing. And then the final decision that's made, and this is not all made the moment I meet someone, but the final decision that's made is whether to do reconstruction. And that is something that you'll hear much more about from Dr. Butterfield in a couple weeks, but she and I will work together. I will do a mastectomy and she will start, put in the beginning of a reconstruction. So it is really wonderful from a cosmetic standpoint. We can occasionally do that, even saving all the skin. So doing nipple sparing mastectomies, and she will describe all that. The downside of that is that it's more surgery. And again, compared to doing mastectomies and being just left flat, it's more risk of complications. There's usually more procedures involved. But again, for some women, and again, this is just the nice thing about breast cancer in this day and age, is that you can explore all these possibilities and find out what really matches and works for you. The other important part of this is first knowing that, okay, you can do both sides mastectomies. It's not going to let you live any longer, because what becomes important is the type of cancer, and really the specific cancer cells. And Dr. Donovan, who's the medical oncologist, is going to talk about that. Who needs chemotherapy? If you have cancer cells or breast cancer that you need chemotherapy, it doesn't matter what you do with your breasts at all. And that's another really important point, because I think, and it makes sense that you come in saying, boy, if I do mastectomies, then I'll be done and I won't have to think about chemotherapy or any of that stuff. You're still have to think about that, because surgery, radiation really just take care of breast tissue, doesn't take care of anything that might have circulated out of your breast. So that's where you still have to think about chemotherapy or hormone therapy. So the surgery decision is really important. There's no wrong decision about what surgery to do. And it can be something that you really work for to make a decision that fits with you. When I meet someone, as you can imagine, this is an overwhelming thought and discussion and choice to make. The way I help with that off the bat is I've got great reading material, and the books all say surgical treatment decisions, because that is sort of the first and foremost in your mind as you're coping with this new diagnosis. For women who are thinking about doing a lumpectomy, I most often will have them meet the radiation oncologist, because it's so important to, when you do a lumpectomy, to be ready for radiation and really understand what that is. It's another great way to get a second opinion. For some women, that I have them meet Dr. Butterfield, plastic surgeon, to learn what reconstruction is. Some women say, I want to do both. I have no idea what I want to do. And so they'll meet with the radiation oncologist and Dr. Butterfield to really make a decision that sits right. And I love it when a decision's made that way, because then you never look back. You never say, oh, well, maybe I should have learned more about plastic surgery or something like that. And again, women in general are great about gathering information like that, just going out, and as much as it seems impossible to make the decision that's right when you come in and meet me, you can. And again, there's a lot of tools, a lot of support, a lot of discussion that goes into that very important decision. So in summary, I would say, yes, if you're diagnosed with a breast cancer, you do have to think about surgery. Yes, when you're diagnosed, you most often start down that whole path after you've met the nurse navigators, meeting with me. And I always describe that first meeting as it's the playing field. You want to know what you're dealing with, whether this is a simple cancer to take care of, whether it's going to be one we'll have to think about chemotherapy or something, and then really go through the surgery decision making. The timing on all this, and we all try to get women in really quickly, just as a need to know basis. It's not an emergency. And I would say most women, from the time they're diagnosed and meet me, it usually takes them a couple weeks by the time they've gotten their full evaluation with the MRI scans or whatever. They've met Dr. Rossi, who's the current radiation oncologist. They've met Dr. Butterfield. It usually takes a couple weeks to make that decision, which is really time well spent. So it's, you know, I will love to take questions, but I think everyone should know that yes, there are choices. If you happen to be diagnosed and someone tells you, oh boy, you should get mastectomies, you should be at least well armed to say, no, I don't have to do that. There's really good choices, and I'm not going to be making a bad decision by deciding to do less surgery. And I think that's about it. You know, I appreciate everyone's attention. It's, you know, it's a busy time of night. It's a busy time in life, but I just think the more you know, it helps you if you need help ever in the future. Someone you love, someone you know is going to have to face this diagnosis. And for me, it's really powerful to think about my grandmother. I bring that up a lot just because, you know, it's a different world, and she would have lived longer than 70 years if she lived in 2022. So now that I've cried, I'm going to see if anyone has any questions.
We have a couple and a lot of thank yous for that. Several people said, you know, thank you. That was good for me to hear because I had been to see someone who told me I didn't have many choices. A couple of other questions that we got were kind of around recovery. And I know that's probably a big topic, but if you can maybe just address real briefly.
So if you couldn't quite hear that, the first part was that it's good to hear there's choices. And I think that that's the world of medicine right now, is that you need to be an advocate for yourself. You need to be educated, and that's nowhere, well, this is my bias, it's nowhere more true than in breast cancer. But recovery is tremendously different. I mentioned that with a lumpectomy and sentinel node, it's outpatient, and usually women will take less than a week off from work. I don't give any pain medicine except some really Tylenol, ibuprofen, ice pack, similar to the biopsies, and then you're back. When I do a mastectomy without reconstruction, it's still a night in the hospital, but it's a much simpler recovery and much less pain than if we do reconstruction. So I'd say most women after that will take 3-4 weeks off, recover. And then I didn't talk about either what we do after surgery is that there's, you know, bras, prostheses. A lot of women will just wear a little cami with the pad. So a little camisole. So there's a lot of ongoing care and figuring out how to look as you're flat chested. If you add reconstruction, it's all more. You know, it's still a night in the hospital. The good thing about pain medicine for any mastectomy now, the anesthesiologists do nerve blocks. So we're doing much better with the postoperative pain than we used to. And even in COVID, when we didn't want anyone to be in the hospital, we were sending, it sounds cruel, but it really worked fine. We were sending women home the same day, even after doing mastectomy with reconstruction. We can do that well with the pain medicine. But you do go home with muscle relaxants, narcotic pain medicine, which usually is needed for several weeks. You see Dr. Butterfield a lot when you do reconstruction, because not to go into her details or steal her thunder, but it's sort of an empty water balloon she puts in. And then you see her periodically as she fills it up here in the office. And then there's one more surgery to take out that what's called a tissue expander and put in an implant. So I'd say all told, most women take probably 6 to 8 weeks off, but then, you know, kind of have to face another surgery coming up. But the advantage being that you don't have to worry about breast prostheses or anything like that. So that's the answer about recovery.
Perfect. I think that was the big one. There were a couple that kind of all included the things that you just covered. So that was perfect. So thank you. That was great. And then stay tuned for our next one.
Yeah, so stay tuned for the next one. It will be, and I've got it written down here, Dr. Butterfield bragging about what great work she does, because she really, we're so lucky to have her here. She's a terrific plastic surgeon and does really well with breast reconstruction. And she is going to be speaking on November 16th. And then after that, we meet the medical oncologist, radiation oncologist, genetic testing, and then survival lifestyle recommendations. So we'll take you through till April. Yeah, I appreciate everyone being here and thanks for some questions, and you can always reach out, correct?
Of course.
Okay,
And we do have your email, so if you have any comments that you want to send even afterward, they should come through and we can respond via email too.
all right. Thank you. Thanks for listening.